Welcome to our frog hospital. We run a cardiac emergency room where frogs can be admitted for various heart conditions or problems. We take pride in informing our patients and their families about the physiology behind their diagnosis. Today, we had 4 patients transported to our hospital for treatment. Here, we will take you through each patient's visits, their diagnosis, along with the physiological explanation we give to the patients and their families. Disclaimer: this is not a real hospital. Results will not look exactly like this in actual living frogs or humans. Our data relates to isolated frog hearts hooked up to an isotonic transducer, where less mechanisms are available due to the removal of other bodily systems.
Our first patient came in alone. He believed that his heart was beating abnormally fast. When we recorded his ECG and contraction data, it came out normal. We saw that the ECG had all the common waves seen in frog hearts. The RR interval was recorded, allowing us to calculate heart rate, which was found to be normal. The QRS complex and TSVP were present, thus we know his ventricles were able to contract and his sinus venosus and atria were able to relax. The TSVP waves were all present in the ECG, which shows proper sinus venosus and atrial contraction, as well as ventricular relaxation. The time interval between the start of ventricular contraction and relaxation were normal, thus his QT modified interval was not abnormal. His PR segment was also normal. This records the time between atrial and ventricular contraction corresponding to the spread of electrical activity from the atria through the AV node into the ventricles. From his contraction graph, we can see that his heart was contracting and relaxing at regular rates, generating a regular systolic contraction amplitude. Since his test came back normal, we sent him home and told him to rest.
Our second patient came in after accidentally injecting many vials of isoproterenol into their bloodstream, thinking it was insulin. We recorded the ECG and contraction data upon arrival and compared his results to a healthy frog heart. This allows us to better understand what electrically and mechanically is being affected in the heart. When compared to the control, the heart rate increased by 31 beats per minute, the QT modified interval decreased by 0.3 seconds, the PR segment decreased by 0.07 seconds, and contraction size increased by 0.05 millimeters. When a patient injected themselves with isoproterenol, the beta-1 adrenergic receptors within the heart contractile cells were activated using the GS-alpha subunit to convert GDP into GTP. GTP then activates adenocyclase, which uses ATP to produce cyclic AMP. The increased presence of cyclic AMP activates pKa. pKa phosphorylates phospholambda, which regulates the circuit-2 pump activity, relieving its inhibition. This caused an increased amount of calcium reuptake happening in the sarcoplasmic reticulum. Additionally, activated pKa causes increased activity of L-type calcium channels and ribine receptor 2s, which further increases the amount of calcium in the contractile fiber. The increase of calcium causes more contractility or a positive inotropic effect from more actin-myosin cross-bridging occurring. Increased calcium causes a shorter phase 2 calcium plateau on the action potential graph since LTCCs close much faster. This reduction in action potential duration contributes to a shortened QT modified interval observed on the ECG, reflecting a faster transition between ventricular contraction and relaxation compared to the control. When looking at the ECG and contraction recording, we also saw an increased heart rate and a decreased PR segment. Within nodal cells, when isoproterenol was injected in our patient, the beta-1 receptors activated, causing the GS-alpha subunit to convert GDP to GTP. The GTP activates adenocyclase and turns ATP into cyclic AMP. Cyclic AMP activates funny channels, bringing in more sodium into the cell. Cyclic AMP then activates pKa, which then increases activity of LTCCs, increasing the amount of calcium into the cell. Increased calcium increases the phase 4 and 0 slope, as well as making it easier to reach the threshold. This allows more action potentials to fire, causing an increased heart rate or chronotropic effect. Since the funny channels are now open and letting sodium in, the time it takes for depolarization is much quicker, increasing the phase 4 and 0 slope. Thus, the time it takes for spread of electrical activity from the AV node to the ventricles decreases, causing a positive dromotropic effect and decreased PR segment. Based on these results, we kept our patient overnight and gave him medication to lower his heart rate and tried to flush out the isoproterenol. Once his vitals were stable and normal, we sent him back home.
Our third patient came in after consuming 10 cups of coffee and complained of his heart feeling as though it was going to be out of his chest. When the frog arrived at the hospital, an ECG was recorded as well as the heart's contractions. When compared to a healthy frog, the frog who consumed 10 cups of coffee showed an increase in heart rate by 3 beats per minute. The modified QT interval decreased by 0.02 seconds. The PR segment decreased by 0.04 seconds, and the SCA increased by 0.16 millimeters. In the caffeinated frog's heart, he had both contractile and nodal fibers, which were affected by the excessive caffeine consumption. In the contractile and nodal cells of the caffeinated frog's heart, adenyl cyclase, which has naturally occurring enzymatic activity, uses ATP to produce cyclic AMP. Cyclic AMP in a healthy frog is degraded into adenosine monophosphate with the enzyme phosphodiesterase. When the frog patient consumed an excessive amount of caffeine, the caffeine functioned as a phosphodiesterase inhibitor, preventing cyclic AMP from being degraded. As a result, cyclic AMP accumulated in the contractile cells, which increased the overall activity of protein kinase A. The increase in pKa activity resulted in the same effects seen in our isoproterenol patient. We saw a positive inotropic effect or increased contractility. We also saw a shortened QT modified interval. Additionally, we see an increase in heart rate or a positive chronotropic effect, as well as a decreased PR segment and a positive dromotropic effect. Based on the results, we kept our patient overnight and gave him medication to lower his heart rate and reduce his contraction size. Once his vitals were stable and within a healthy range, the patient was discharged.
Our fourth patient came in after consuming 30 bananas, as they are his favorite fruit. He was pronounced dead upon arrival. When he arrived, his ECG and contraction data were taken, which confirmed his heart was no longer beating. All electrical and mechanical activity fell to 0. When our patient ate this many bananas, a high source of potassium, it caused a great increase in the extracellular concentration of potassium in contractile cells of the heart. In a healthy heart, contractile cell action potentials begin with sodium channel activation, causing a large influx of sodium into the cell. This is the depolarization event of the action potential, or phase 0. In order for repolarization back to rest, potassium has to flow out of the cell, following its concentration gradient. At this point in repolarization, time-dependent sodium channels inactivate. However, with high levels of extracellular potassium, there is no concentration gradient for potassium to leave the cell and cause repolarization. This effect can be explained by the Goldman equation. An increase in extracellular potassium is going to increase membrane potential, making it more positive, or depolarized due to the decreased potassium gradient out of the cell. This leaves sodium channels in their inactivated state, unable to fire another action potential. This is because they require repolarization in order to deactivate and then reactivate for the next action potential. The persistent depolarization of cells is called a depolarization blockade. If contractile cells can no longer generate action potentials, then calcium will be unable to enter the cytosol of the cells and cause muscle contraction. Without heart contraction due to the absence of action potentials in contractile cells, the heart will stop beating. Each heartbeat is the result of action potentials spreading throughout the heart. The ECG recording is picking up contractile cell activity only and will therefore no longer show any heart activity. The contraction data will also no longer show any activity, as no contraction will cause no change in length of the heart. Therefore, by eating too many bananas, which are high in potassium, the frog's heart stopped beating, resulting in death. We spoke to the patient's family and gave our condolences before sending him to the morgue.
Thank you for visiting our hospital and listening to today's cases. We hope you learned a lot about how various drugs or nutrients can affect the heart of frogs.